I'm a medical virologist. I work in the field of emerging and re-emerging infectious diseases, specifically viral diseases. And we know that these emerging and re-emerging diseases are becoming a big issue. You know, every day you listen to the news, there's an outbreak here or there. It's something that, and it results in a lot of morbidity and mortality. And so it's important that we do research, you know, for us to be enlightened, to understand these infectious agents the more, so that we can come up with diagnostic kits, vaccines, treatments, you know. And of course, we know that currently it's a global village. The world is a global village, and infection in one point can spread very rapidly to another. So we do not work in silos. We work even with other researchers in different parts of the world. We started in Ondo State. My team, we went to Ondo State. There was an outbreak of Lassa fever in Ondo State. And as at that time, it was the biggest, you know, more mortality and morbidity. So we were there, we collected the samples, we interviewed people. And by the time we did the screening, just like we see even now, we found some positive cases from amongst those suspected cases in the hospitals, from amongst health workers, from amongst their contacts, their relations, and from the people in the population. We were able to pick some positive cases. But one thing that struck us was that out of about all of the samples that we collected, about 80% of them, from suspected cases, 80% of them, we were not able to identify Lassa fever. We couldn't confirm Lassa fever in these people. And it gave us some concern. It means there are some other things causing infections that mix Lassa fever, the symptoms of Lassa fever, that we are not looking out for. And that was how we expanded the scope of our work to look at viral hemorrhagic fevers as a whole, you know, the panel of viral hemorrhagic fevers that are common in Africa. The infections are ongoing. And then, so when people come with fever to the hospitals, it just means that our health workers also should have a high index of suspicion. When you screen malaria is negative, think viral hemorrhagic fever. It could just be any one of this. And then we also found the abundance of these Aedes aegypti mosquitoes. Means that it will also facilitate the transmission of these viruses. Okay, so we will have to find a way to control them and control them more effectively. Then also, public awareness is also something we need to build on. We just need to get people informed. Many times, people just off-the-counter treatments. They don't get to the hospital. They just treat themselves. They had fever last week. They treated. They are having fever again. Their self-medication and all of that is not going to help. So we need to educate the public. You know, beyond malaria, there are many other things. And anti-malarials will not address viral agents. Along the line, as we're working on the viral hemorrhagic fever, the COVID-19 pandemic came knocking. And in this institute, we sequenced the first index case, though partial sequence we did. We're the first to report that. What that means is that when you know the characteristic of the virus you're working with and you are able to load it in the gene bank, when they are going to develop vaccines or develop drugs or diagnostics, they will also take from your own, okay, and include. And that's why, because we have not been doing much of this sequencing in country, because we have not been looking for these agents mostly. Sometimes the kits we get from abroad, we use them and they are not able to pick cases here in Nigeria. So we were able to develop it. And so when we talk about sequencing, that is just the beauty of it. That is the added advantage, that what we have can be reflected in any diagnostics or vaccine or therapeutic. So they will need to test it. So we need to have diagnostics. We have what we are using here, but we're using ours for research because it's PCR majorly. Not many labs in Nigeria can have access to PCR, maybe the tertiary. So we still need to improve on what we have to probably get serology kits that will be available for labs to use. I see this this media chat as really very, very important, because I'm sure it's going to enlighten the public the more. So, in conclusion, I'll say that emerging and re-emerging infectious diseases, particularly viral hemorrhagic fevers, are common in Nigeria. From the results I have presented so far, you will agree with me that it's really with us here. So highlighting the need for screening of febrile patients, okay, not just for malaria, but some of these viral hemorrhagic fevers. And so to better address this, we need improved diagnostics, vaccines, and even treatment. And then additionally, we need to enhance surveillance systems in Nigeria. We need to enhance surveillance. I'm just hoping, let me just add that one here too, that from this one too, I'm hoping that our DG2 will give us funds to continue this research that we are doing, so that we'll be able to get some more information that will help us in the management of these agents.
So tuberculosis is caused by a germ called Mycobacterium tuberculosis. There are so many genus of mycobacteria. We have the Mycobacterium tuberculosis, Mycobacterium rep, and the non-tuberculous Mycobacterium. And all these cause diseases in humans. The mainly focus is mainly on Mycobacterium tuberculosis complex, which affects the lung, the pulmonary TB. So here we do research in that area. We also able to know that most of these patients that suffer from TB, they also have drug-resistant TB. And this drug-resistant TB, they are the TB that are hard to treat. For TB, we have what we call drug-sensitive TB. Those ones, we have drug to treat them. TB is treatable and curable and preventable. But when it moves from TB to drug-resistant TB, the treatment becomes complicated. And most of the drugs available will not work. That's why most of the patients stay longer in the treatment. So here in NIMA, we researched into that. We're able to see that the prevalence of drug-resistant TB is high in Nigeria. As we all know, TB is endemic in Nigeria. So recently, we were able to move further to TB genomics, where we were able to know that most of the diagnostic tools available for diagnosis of TB in Nigeria are not really giving us prompt response to diagnosis. It takes a longer time, like 8 weeks to get your results. So that's when we introduce molecular diagnosis for TB. With molecular diagnosis, the diagnosis is rapid so that the patient can be diagnosed and put into treatment. So now we have done some researches in that area. We have collaborated in that area with other institutions, and we have some fundings to do research in that area. So currently there is a national drug-resistant TB survey going on, which NIMA is part of it.
I am thinking that with this media chat that we started, we will be able to explain these things better, so that, and I'm sure you will be able to transmit it to a wider population. There's a lot of false information out there, plenty of it, but most of it is unfounded, is not true. You know, I don't know, but it's just not true. Vaccines are good, they are safe. There's a lot of process that goes into it before they release them into the market, and they even monitor them while they're in the market. So anybody that says the vaccines are not good at any point in time is not true. Vaccines that are in the market, whether for the human papilloma virus, whether for Mpox or COVID, they are safe. That I can say. The take-home message is that viral hemorrhagic fever, we have seen so many of it, the different agents here in Nigeria. So beyond people who have fever, it is not just malaria. And then sometimes when they have some certain symptoms, they may think, okay, it could be Lassa. Beyond malaria, beyond Lassa, we have other viruses, viral hemorrhagic fever in that class that are abound in Nigeria. I also told you that even the Mpox, they said, oh, it was a public health emergency of international concern. But when we even looked into our stored samples, we saw that, look, a high prevalence there. So we have many things that are circulating around. So what are we saying? That number one, our health workers should have high index of suspicion. By the time you screen and it is not malaria, think viral hemorrhagic fever. Individuals, please don't just take self-medication. In fact, even on those drugs, they say after 2 days, if you are not improving, go and see your doctor. Please don't let us, you say you treated yourself last week for malaria, you are treating this week again. And you know, we just keep bombarding ourselves. Before you know, you even develop resistance for even the malaria itself. So people who have fever should go to the health facility. If after 2 days they have taken paracetamol and stuff like that, they should go to the health facility. When they get to the health facility, they screen for malaria and then they should think of viral hemorrhagic fever. That is the take-home message, that it is here with us. The question of herd immunity. I think I mentioned herd immunity when we're talking about the COVID-19 seroprevalence. So what they mean by herd immunity is to see the, trying to use layman language, the antibody level, to know if they are protected. We want to know, like in this place now, in this room now, if at least 70% of us have developed antibodies to an infectious agent, it just means that somehow we are protected. So even those who have not, in interacting with us, they could also get some immunity, you understand? And they will get protected. They get some asymptomatic infections and then they get protected. So they are good. They are safe for that agent. So talking about this room, we're now talking about our country. If majority already have antibodies, then there's nothing to worry about. Because I recall during that COVID-19 time, it was like, hey, these vaccines are coming. Why are they coming? Are they bringing them to Nigeria? Is it, some people, it's like, we don't even know the level of immunity that we even have. If we already have it spread already, do we still need the vaccines? So we had to do that study, and we found that no, majority do not have, even though infection is going on, it's a new virus, even though infection is going on, but majority do not have, and they will benefit from the vaccine. That was when I mentioned herd immunity. Healthcare workers, they are the first that really attend to these patients. And most times patients go when they are really bad. I mean, the condition is bad. They have tried several and they are not improving. That's when they get to the hospital. So if you are able to check their viral load, it's usually very high. So they are infectious. People they come across could get infected. And then we have some of these facilities that don't have enough infection prevention control. They don't have personal protective equipment. They don't have gloves to use. They don't even have running water to wash hands. In some health facilities in this country, it's really pathetic. Whichever way we will have to do this. Sometimes they even tell the patients to go and buy the gloves and buy everything for them to take care. How much of that can we do? We need to protect our healthcare workers. You recall that during the Ebola crisis, the outbreak in West Africa, 2014 to 2016, that period, in some other countries, you just hear that the health workers will just die like that in hospitals. If we lose these health workers, I mean, who will now manage the cases? Who will manage? And we know that it's not something that they go through training. It takes years to train these people, plus the years of experience. So we need to protect our healthcare workers.
With proper treatment, if the patient is able to complete his or her treatment, then he can be cured of the MDR-TB. We have capacity here in NIMA to detect drug-resistant TB. We have the molecular method, and we also have the conventional method, which is culture and phenotypic drug susceptibility testing. So those are the methods to use to detect TB. And I said earlier, now we are moving to genomics. With genomic, you can also use it to detect drug-resistant TB, and it's faster than the ones we have been using, the conventional one, which takes like 8 weeks for culture. Then if you want to do the drug sensitivity testing, it takes 3 to 6 weeks. So the molecular method now is shortening the time for diagnosis so that the patient can be put to treatment promptly with the correct drugs. There are newer drugs now available that they use to treat multi-drug resistant TB. So those newer drugs now, we also have them test them in the lab, and we discover that most of the MDR patients, they are responding to the treatment. But these drugs are not readily available because they are newer drugs. For you to get them, you have to go through the National TB Control Program. So the National TB Control Program have drug treatment centers where those patients can go to, and the treatment will be administered to them. So if you go to the patent stores, you will see all those drugs. That's why the National TB Program control the TB diagnosis and management. So the patient have to go to the hospital that are working with the National TB Program and get treated. So those drugs are effective.
Okay, so like I asked again, sorry, to that question, that's how do you manage your patients? Yes, they come in NIMA for their treatments because it's a center. Those other ones who go to other facilities, how do you reach out? I mean, what kind of collaboration do you have, especially
reference lab?
Let me say Lagos, because in all the studies I've had, we're talking outside our immediate environment, and all that. Do we also have Lagos as part of?
Yes, NIMA harbors the National TB Reference Lab. We serve Lagos State. We work hand in hand with Lagos State TB Control Program. So most of the sample collected from other sites, public health centers, they are bring to NIMA, where we test them and do the drug sensitivity testing, and we communicate back the results back to the Lagos State. Lagos State has a treatment center for drug-resistant TB. So those patients are called back by Lagos State, where they will do other baseline investigation for them and then put them on treatment. But if it's drug-sensitive TB, now we have a DOT clinic where those patients come for treatment. They monitor their treatment for them. Then when they are free, because monthly they collect samples for them, where we do and monitor them, so that we see that those patients have converted from being positive for TB to negative. So once they are done, they are discharged pure. The outcome, then the patient is free.
You find that people come here to apply to be interns for 6 months. Oh, I'm interested in research. I had a 2-1. When you see that person now and you ask, because I tend to interview many of them, why do you want to spend 6 months in there? Eventually you get to know that they just want to add it to their CV, package their CV, and go to the British Embassy. Apply to different schools. So they want to get over the hurdle of do you have experience in this area or not? And that's why they just want to go. Our government will have to do a lot to stop people from going. And Prof. Audu did make the clarification between PhD students and postdocs. I was actually referring to postdocs. We're yet to advertise for those ones. As for PhD students or MSc, my expectation is that by the time you are applying to a university for a doctorate or a master's, you already have an idea what you want to do. The university that's accepting you should know their capabilities. So it's not that you go into the university for that program and then you start thinking of what to do. So I don't want us to have the impression that NIMA has the responsibility for supervising PhD students all around the country. No. If you have a PhD candidate looking to work in an area where you have an expert resident in NIMA, that supervisor or that lecturer can now liaise with that NIMA expert to co-supervise the candidate and allow the candidate the opportunity to utilize the equipment within NIMA for the purpose of the PhD dissertation. As for collaborations, yes, we do have collaborations, whether it's with NAFDAC or the Institute of Human Virology and all the rest. NCDC. In fact, currently we are supposed to be working with NCDC with regards to the HMPV, human metadenovirus. NIMA is expected to develop the diagnostic process in case we have that problem. So much was voted for NIMA. NIMA could do a lot better. Or should I say, we could have been given something much more. I want to assure you that we are not taking this for granted. And the more you ask questions, the more we will probably be able to look at some other areas we've not been focusing on. There's going to be something to gain from these interactions. And like I mentioned before, we intend to do this over the next 20 to 22 months. We have enough people working in NIMA. Actually, I was thinking that at the end of this session, some of us might be interested in going with Rosemary Audu to our laboratory to see what's going on in there. If I'm allowed, I want to invite those who might be interested to have a look at what's going on in the place. Sadly, a number of the equipment were acquired as a result of foreign donations. Some of them, like I said before, are temperature sensitive, and we can only hope with your assistance we'll be able to convince some policymakers to come to our aid. Again, I want to say a big thank you, and we hope that you come around again to spend some time with us in about 4 weeks' time when we bring to us another senior researcher who will be talking about some other things. That said, I want to say a big thank you to Professor Audu. Dr. Kunle Okwe, I thank you. Professor Ezechi, thank you. Professor Petrus, the director of ASME. I thank you, sir. Mr. Efirero, a media consultant. Maybe it's not the appropriate time for me to say it, or I'm not supposed to say it. Something was mentioned along the line about science correspondence and what have you. We've thought about it in-house, and we hope that sometime soon we'll have a forum with the assistance of some resource persons to have a session for, we call it science journalists. When that comes, we'll invite us to participate. It's supposed to be a training session or something. And I appreciate what is said now about the use of medical jargon. I hope I've not used any medical jargon. One of the things you are taught in forensic pathology is that you have to break down your language, make it simple for the court to understand. I must say that I've listened to some journalists in the area of science, and I have tremendous respect for them. The way they're able to not just comprehend, but also break things down. I'm sure we'll benefit from that session when the time comes. That said, I thank us, our colleagues. Is it the fourth realm? Okay. Fourth estate of the realm.
After the judiciary, we are the next.
We are at the bottom somewhere. I thank you for finding the time to come. I'll always remain grateful. On behalf of NIMA, I wish us well and safe journey back. Thank you.